Good morning. So I'm Abbe and I currently work at IDEO. And this morning we're going to talk about healthcare delivery, redelivered, and look at some of the things that are going on right now in the healthcare system and why it's ripe for disruption and invention, and some of the ways that Tom and Jordan are pursuing that. So with that in mind, why don't we start with you, Tom, and tell us a little bit about what you're doing with One Medical and what prompted you at this moment in time to pursue this approach.
The question is what prompted me at this time. The reality is, we've been working on this for quite a while. The short story is, I'm trained originally as an internist out of Seattle and Boston. From the inside, I saw a lot of what Andy was mentioning, just the dysfunction, both on the provider side, the system side, and really not being able to advocate for the patients the way we originally envisioned. So really I wanted to kind of figure out what was wrong with this healthcare system and dig in deep. There was actually well-intentioned people, but the way the system was designed seemed flawed. It wasn't delivering all the expected value that you'd expect for something that was putting so much money into the healthcare system. The outcomes were just so poor and really not what you'd expect from a clinically well-organized system. So I dug in deep and really over the last 5+ years have been working on building a next generation model of primary care. So leveraging technology experience, some of the business kind of understanding, trying to redesign a model that's more mission-oriented and focused on delivering what's great for patients, while also lowering total healthcare costs. And that can be done because the system is so inefficient and so non-transparent. So briefly, One Medical Group does same-day appointments, longer visits, more accessible patient care for kind of a whole group of populations. We have offices in San Francisco, New York, and DC. But to Abby's question, it's not why now, it's why over 10 years ago when I was thinking about this. And the reality is it's because the system is so terrible. And it's been terrible for the last many, many decades. And it's because it's not designed with the consumer or patient in mind. But,
I think I remember 10 years ago at the bar when Tom and I were talking about changing healthcare and the different models. My perspective is slightly different. I went to Georgetown Med School, did my residency here in San Francisco. Just by way of brief background, I joined the HMO of Brown and Toland in 1997 to kick off my career. And after 1 year of 25 patients a day and really treadmill-style medicine, my father was the chief of surgery at the big hospital here, and I walked home kind of dejected, thinking, this isn't my life, this is not what I signed up for as a doctor. And my office was on Montgomery Street, I lived in North Beach, and I walked by the Mandarin Oriental Hotel, which, I don't know if you know that hotel, I didn't at the time, but it had 5 stars next to it. So I walked in and I said, who's the doctor for this hotel? And they said, and who are you? And I said, well, I'm a doctor that I think maybe could be the doctor for this hotel. And and I looked like I was 18, because this was 15 years ago. And they said, well, we need to know who you are. So I put together a little package on an old medical chart with a little dossier on who I was and my background. And they said, listen, we're a 5-star hotel. You have to deliver a type of service and a quality of service that you probably are unfamiliar with. And I said, well, fair enough, give me a shot. And so they gave me a shot. And I say this by means of, because it's kind of for me, it's kind of funny. In 1998 is when I did, so I was the doctor for the Mandarin Oriental Hotel. And and they said, listen, if a guest wants you to do a house call, you're coming and doing a house call. And I said, okay, I just live right up the street. I got a doctor bag and I'll figure it out. And I kind of cut my teeth on what is now the term concierge medicine, but I learned from the concierge at a 5-star hotel how they treat people. They've got all the lapels on their jackets of why they're great at customer service and hospitality. And so I kind of got in the head of those concierges as I was taking care of those guests, and have kind of always tried to bake into the model of delivery, what does the patient want? What is the patient thinking right now? What are their anxieties? And how can I navigate that? And to Andy Grove's competition theory, I have a corollary to that, which was, I think it was Porter. Your slide was insight into the best results gives advantages to the patient. And I think my corollary to that is insight into the patient gives results the best advantage. Because I think in a lot of ways, the paradigm of delivery today is don't just stand there, doctor, do something. And I think that we need to, as internists and as primary care doctors, don't just do something, stand there. let's hold off for a minute. Rather than just jumping into doing something, which is what everybody wants, because doing something has the plausible explanation of something that happened, is sometimes just stepping back. And I'll go to my favorite quote by Voltaire, and then we can kind of have a conversation, is that, it's on my wall, Voltaire said, the art of medicine is to keep your patient in a good mood while nature takes its course. And I really take that to heart, because a lot of times the body fixes itself, but yet we intervene with a bunch of stuff that actually causes more harm than good. And if we just are patient and we can actually get to a good result without mucking around and causing expense and doing a lot of unnecessary things that we don't really have evidence for. So I'll stop there. And then, I'll stop there.
And then, so both of you are practicing physicians, and both of you have an entrepreneurial spirit and are influenced by being around the Bay Area and the sort of startup mentality as well as technology. And I know that both of you are looking at different ways in which technology can improve or impact how you deliver the particular model of care that you're pursuing. So I'm wondering if you might talk a little bit about what you're doing with technology in your particular practice, or Jordan, in your case, with HealthLoop.
Yeah, so one of the vexing problems for me, and probably everybody in healthcare that's a doctor, and some doctors don't care because it's not a data set they're familiar with, but as soon as if you're in my office and I'm looking at you, or you're in a hospital and the doctor's looking at you, or you're in the clinic and someone's looking at you, you kind of have someone's undivided 100% attention. And then you leave. And you leave with evidence-based medicine diagnosis and evidence-based medicine treatment plan. And then you go home and you are completely alone. And you have no idea what day 1 looks like, what day 2 looks like, we don't, And so many years ago, a 78-year-old woman came to my office with pneumonia, and I prescribed her the best drugs for the thing, and she went home, and I gave her my cell phone number, and I wanted to make it frictionless for her to get me if she needed me. And I said, look, you're on the older side, you're a little fragile, bad things can happen, call me if you're not feeling better every day. I got a phone call 8 days later from the ER. She was being admitted to the ICU, being intubated, and I thought, why didn't she call me? I made it almost as easy as possible. And then I thought, well, shame on me. Why didn't I call her? I should have been checking up on her on some form of a regular basis, because for crying out loud, I knew that she was fragile. So then I thought, well, the system's not designed for me to be calling everybody every day, but I did. I created a spreadsheet and I started calling everybody who was category 1 for me every day. Are you the same, better, or worse? And if they said better, I would move them over, and eventually I'd get them off this spreadsheet. And my spreadsheet got really hairy at some point, because I went on vacation. My partner said, I don't know how your brain works and how your algorithms in your brain work regarding the spreadsheet. So I hired a developer, and I built a little software thing to track my patients, asking them one question. Are you the same, better, or worse today than yesterday, as a global thing? And then that turned into other doctors saw it, patients liked it, I gave it to my buddies, they used it, and it kind of spawned a different category of doctors wanting, well, I really want to know this on day 4, and I really want to know that on day 8. And so what HealthLoop really is it's an extension of, once you leave the office, you get the electronic house call. So I do physical house calls with my doctor bag, I still do them. But this is the electronic house call that tethers you, the patient, to the doctor around very specific issues that you have. So in a way that evidence-based medicine is, there's really no evidence for evidence-based medicine, but we can have the argument later, is there's this concept of experience-based medicine, which is, what does the doctor do when he answers the phone 3 days after you've left? He says, or she says, that's normal, or that's not normal, based on my experience and my pattern recognition of this diagnosis, this drug, this plan on this day. So doctors really manage by exception today. And I studied the phone logs of a busy orthopedic practice, and 120 phone calls came in a day, and of those phone calls, based on the diagnosis that was predicated on the phone calls, they're predictable. There's no new phone calls coming into a doctor's office today. They're all the same, and they're all predictable, and they're all predicated on a diagnosis and a treatment. So why not codify that and give it to the patient and let them understand their longitudinal path once they've left? And then the doctor can kind of look at their dashboard and get alerts when someone's wobbling out there, because a lot of people have never seen that movie before. And they don't know that Act 3, Scene 4 looks like that, and they're just hoping they're better every day. So I'm trying to kind of get into the space of after the visit and the rich data sets that exist. Because people, right now, hey, come back in a week, follow up in a week, follow up in 2 weeks. It's arbitrary, that duration of time, and a lot of those visits are unnecessary, but they're pro forma for legal reasons and liability reasons and what have you. So that's one of the problems I'm trying to solve, and you know, primary care is difficult. I tried to build loops, feedback loops, HealthLoop for primary care, and there's just so many of them. So we've gone after specialty-specific orthopedic, gynecology, urology, cardiology, because they do majority of the things in their routine and they're predictable, and so just building out these predictive analytics and models, and so that's where I think is interesting.
Yeah, so for us, it's hard not to kind of be influenced by technology in the San Francisco environment. I think it's not a surprise to see more innovative practices coming out of this region because you're so surrounded by technology transforming society outside of healthcare. I think the real question is, why is it not permeating healthcare more pervasively? And I think the way you deconstruct it, the way I do it, is it's not just technology, it's information technology. If you look at device technology has permeated healthcare very well. But information technology has not, and again, the easiest root cause is the financing system. It reinforces a delivery system that doesn't reward information technology and/or efficiency. So our goal was to decouple ourselves from the bizarre economic incentives of the system, re-engineer our operations so we can recalibrate our operations towards consumers, and design value-based systems using information technology. So by realigning the organization's mission and focus, we can use technology to then better deliver higher quality care more cost effectively. And we intentionally avoid what I call the crack of fee-for-service, you know, pay as you go, do more to people medicine revenue. We say no to that. We say fewer patients per day. We email patients even though we're not generating revenue from it. We're designing mobile apps where people can kind of communicate with their doctor. If you've got a urinary tract infection, you can go directly to a mobile phone app and get it treated without speaking to someone if appropriate. And all these things are available to us today. They just don't have the right economic incentives. So what we've tried to do is really shun ourselves from that direction and do what's in the best interest of the patient, independent of how we get paid. And we've run the math on it and worked somehow. So.
Yeah, and I'd add on to that. I mean, I look at businesses as ecosystems where you can kind of see where things go and how things work. But in healthcare, what you really have is a freakosystem, because you can't really know how things work. If you turn that lever, you don't know what happens over there or over there, because of a lot of the stuff that's hidden behind weird financial and Byzantine rules and whatnot. And I think this movement towards accountable care organizations, ACOs, I mean, this is, you know, so I'm like a micro ACO, you may be a mini ACO, and then there's the macro ACOs in terms of we kind of try to manage some risk, is, you know, if you have all these people that are accountable, doctors are accountable, hospitals are accountable, all these various constituents are accountable, I just can't understand how you can have a system where everyone's accountable to 313 million people who aren't accountable at all. And how do you get the people accountable? And I don't mean in a paternalistic way, bad you know, but how do you get people to frame their health as an asset? Okay, I mean, when I go to cocktail parties, people say, what do? I say, I'm an asset manager. I kind of joke around. Oh, what's the asset category? And I say, you know, the physical one. And they kind of laugh. I said, well, you have a house and a car and you have all these other assets. You take them seriously and you're into, you know, preservation of the asset, or you want the asset to last longer. I said, what do you do for your health? I have insurance. I'm like, that's not protecting your asset. You know, that's protection against catastrophe. When the wheels come off, that's what insurance is for. But who's managing your asset? Who rebalances the portfolio every year? You know, and how are you incentivized to participate in that? And that's what Tom and I are trying to do, is I think both of us are trying to kind of reframe the system as, it's not about this doctor to patient. It's a bi-directional thing where everyone needs to be responsible. I mean, I think the good news for our system, and Tom and I have been hacking away in the weeds for 10 plus years on this issue. It's funny that finally today, things are starting to change, and I think the Affordable Care Act, 8 months ago, everybody was, what's the Supreme Court going to do? And there was all this uncertainty about the certainty of the Supreme Court decision. And the good news is now that the Supreme Court has acted, now there's a bunch of certainty that there's going to be a bunch of uncertainty. And that uncertainty gets me excited, because I think that with that, everything's kind of becoming unfrozen. All these big monolithic players are actually starting to look around and say, I may not be relevant in 5 to 10 years. I better do something. So I'm feeling, having been in the industry for 15 years, everyone's actually starting to what are you doing over there? What's going on over there? And I feel like we're on the precipice of potential good change, but we got to get users, and the system has to be built for patients and doctors. You know, it's been built by doctors for doctors, and now we have some doctors trying to build it for patients, but there needs to be 2 UIs on a common platform, and it needs to work for doctors, and it needs to work for patients. And it doesn't right today, although we're trying to change that.
All right, well, thanks everyone.
Thank you.